Welcome to PRISM Rounds, the audio journal club, where we take one high-impact paper and break it down for ICU, ED, and pulmonary critical care clinicians. Think of this as the hallway conversation after rounds, but recorded. Practical, evidence-focused, and always asking, what does this mean at the bedside?
And occasionally asking, should we actually change what we do on our next PERT call?
Yeah, that is the million-dollar question today, right?
Yeah.
Because we're tackling a topic that is, it's the absolute definition of a middle-of-the-night clinical conundrum.
Oh, totally.
We're looking at the much-anticipated HI-PEITHO trial. It was recently published in the New England Journal of Medicine, alongside this really incredibly nuanced accompanying editorial by Dr. Alexis Spyropoulos and Dr. Suresh Vedantam.
Great.
And if you take care of patients with pulmonary embolisms, this is the data you've been waiting for.
It really is.
But before we get, totally lost in the weeds of the methodology and the secondary outcomes and all the physiological mechanics, let's just give you the bottom line up front.
Good idea. Let's start there.
Here is the core takeaway. In intermediate-risk pulmonary embolism, ultrasound-facilitated catheter-directed thrombolysis reduced clinical deterioration without a clear increase in major bleeding.
But, and we have to attach a massive, glowing neon but to that statement right out of the gate.
Go for it.
There is no mortality benefit here. The signal we are exploring today is almost entirely about preventing cardiorespiratory decompensation.
Right, the short term.
Exactly, yeah. It is about stabilizing the patient's physiology in the short term, not necessarily saving lives outright. That crucial caveat has to frame everything we discussed today.
So we are preventing the crash, right? Not necessarily preventing the funeral.
That's a great way to put it.
And to really understand why this trial was designed the way it was and why that specific outcome of, preventing the crash matters so much, we have to establish the clinical tightrope that is intermediate risk PE.
It's such a tightrope.
Right. Before we unpack the new data, we need to look at exactly why this specific patient population keeps clinicians pacing the halls at 2 a.m.
Yeah, and the stakes are just, they're astronomical. The editorial points out right away that pulmonary embolism is the third leading cardiovascular cause of complications and death globally.
Wow.
Third. It trails only behind myocardial infarction and stroke.
Yeah.
And the incidence is rising worldwide. We're seeing more of it. Our imaging is getting so much better, so we're diagnosing more of it. And the patient populations are just getting older and more complex.
Right.
But a pulmonary embolism isn't just one monolithic disease. It's a massive clinical spectrum.
Yeah, totally.
On one end, you have the low-risk patients. They come into the ED. They have normal vital signs, normal heart function. You start them on some oral blood thinners, and they might even go home the same day or the next.
Right, the easy ones.
Exactly. And on the other end, you have the massive high-risk PEs. These are the patients in profound cardiogenic shock. They're hemodynamically crashing. Their blood pressure is just in the boots. And the medical consensus there is actually quite clear.
You just have to act.
Right. You have to get that clot out or dissolve it immediately with powerful systemic drugs, despite the severe bleeding risks.
Yeah.
Because otherwise, the patient is going to die right in front of you.
So the extremes are, relatively straightforward. But then we have this uncomfortable middle ground, the intermediate risk PE.
The gray zone.
Exactly, the gray zone. You're evaluating this patient, and from the doorway, they might look okay. They are hemodynamically stable, their blood pressure is holding, they are awake, and they're talking to you.
Yeah.
But when you look under the hood with your imaging and your lab work, you see signs of severe underlying strain. Specifically, we're looking at right ventricular or RV dysfunction on a CT scan or an echocardiogram.
Plus the labs.
Right. Combined with positive laboratory biomarkers like an elevated troponin.
And to really grasp why this uncomfortable middle is so terrifying, we have to dive into the physiology of the right ventricle.
Let's do it.
Because the right ventricle is simply not designed for heavy lifting. It is a thin-walled, crescent-shaped chamber. Its entire evolutionary purpose is to pump blood into the low-pressure, low-resistance system of the pulmonary vasculature.
So it's a volume pump, not a pressure pump.
Exactly, a volume pump. So when a massive clot or, a shower of multiple clots suddenly lodges in the pulmonary arteries, The resistance in that circuit just spikes dramatically.
Right.
The right ventricle is suddenly pushing against a brick wall, and because it's so thin-walled, it can't just generate more muscle force on the fly. Instead, it dilates. It just stretches.
I always visualize this like a balloon. Like the left ventricle is like a thick, rigid rubber tire. It can handle high pressure.
Yeah, that's a good analogy.
But the right ventricle is like a flimsy party balloon. When you block the exit, it just balloons outward. And because the heart is enclosed in the pericardium, which is this fixed, stiff sac, that ballooning right ventricle has nowhere to go but inward.
Right, it pushes back.
Yeah, it starts physically crushing the left ventricle. The septum separating the two chambers actually starts bowing into the left side.
And that is the exact mechanism of interventricular dependence. The right ventricle, which is normally the skinny, low-pressure sidekick, balloons up and physically crushes the main engine of the left ventricle.
Which is wild to see on an echo.
It really is. That's the RV dysfunction we see. And because of that, the left ventricle can't fill properly because it's being squished, which means your cardiac output starts to drop.
And while all that mechanical crushing is happening, I mean, the heart muscle itself is crying out for help.
Oh, absolutely.
Because that extreme mechanical stretching of the right ventricle causes microischemia. The tiny blood vessels supplying the right ventricular wall get compressed by the stretching. The muscle starts to starve for oxygen, and the cells start dying and leaking enzymes.
Right.
And that's the elevated troponin level we see in the blood work.
And that elevated troponin in this context is just a blaring alarm bell. It tells you the compensatory mechanisms are failing. The heart muscle is actively suffering damage.
Yeah.
So you have a patient whose systemic blood pressure might be, 115 over 75 for the moment, but their heart is actively failing against that blockage. This is the intermediate risk patient.
They're right on the edge.
Exactly. They are on a physiological precipice. Over the next few hours or days, they might slowly recover, or they might completely exhaust their right ventricle, cross a tipping point, and suddenly collapse into full-blown cardiogenic shock.
Which brings us to the decades-old dilemma of how to treat them. Because the foundational treatment for pulmonary embolism was established well over 60 years ago.
Right, Baird and Jordan, back in 1960.
Yeah. They essentially proved that giving anticoagulation like heparin saves lives compared to doing nothing. We give them blood thinners to stop the clot from propagating, to stop new clots from forming.
Yep. And then we just rely on the body's natural endogenous fibrinolytic system to slowly break down the existing blockage over weeks or months.
Right, and anticoagulation is the bedrock because it is generally safe. Compared to other interventions, standard heparin or low molecular weight heparin carries a relatively low risk of catastrophic, life-threatening bleeding.
Sure.
But here is the fundamental flaw when dealing with intermediate risk PE. Heparin does not fix the immediate right ventricular strain.
No, it doesn't touch it.
It doesn't dissolve the clot that is currently choking the heart. The brick wall is still there. So, with anticoagulation alone, you are leaving the patient exposed to the risk of that sudden, unpredictable deterioration.
Yeah, you're basically committing to a strategy of watching and waiting, hoping their fragile right ventricle can hold out long enough for the body to do the heavy lifting.
And anyone who has worked in an ICU knows how nerve-wracking that watch and wait period is. You're just staring at the monitor, watching their heart rate creep up from 100 to 110 to 120, wondering if they're about to code.
It's agonizing.
So the obvious question has always been, why not just dissolve the clot immediately? We have systemic fibrinolysis. We have powerful clot-busting drugs like alteplase and tenecteplase.
Right, and the medical community tried this.
Right.
We actually have robust data on this approach from the older PEITHO trial, published back in 2014. They took over 1,000 of these intermediate risk patients and gave them a full systemic dose of a clot buster, tenecteplase.
And what happened?
Well, the 2014 PEITHO trial showed that giving systemic calytics worked beautifully for the heart. It cut the risk of hemodynamic collapse by about 50% compared to heparin alone.
Which sounds great.
It undeniably worked from a hemodynamic standpoint. It chemically demolished the clot, it rapidly dropped the pulmonary artery pressures, and it took the strain off the right ventricle much faster than the body ever could. But it came with a massive, devastating trade-off that has completely paralyzed the field ever since.
Yeah, I think we need a really clear analogy to explain this clinical paralysis.
Yeah.
Because Treating an intermediate risk PE with standard anticoagulation like the heparin drip is essentially like standing outside a smoking house with a standard garden hose.
I like this.
Right. You are spraying the outside, just hoping the fire burns itself out before the structural from of the house collapses. You might save the house, or it might burn down while you watch.
Right.
But using systemic lytics, the full-dose high-V clot busters from the 2014 PEITHO trial is like calling in an airstrike and dropping a massive water bomber airplane payload onto the house.
Yes, exactly.
Yes, the sheer volume of water will absolutely put out the fire immediately. But there is a very, very high probability that the impact of the water will just crush the roof and destroy the house anyway.
That analogy perfectly captures the anxiety of the treating physician. Let's ground that crushed roof in the actual sobering statistics from the 2014 PEITHO trial.
Okay, hit me with the numbers.
When they administered systemic full-dose fibrinolysis, it carried a nearly 10% risk of major bleeding. That means 1 in 10 patients suffered a significant hemorrhage.
Wow.
But the number that truly haunts clinicians, the reason those drugs are kept locked away for only the most desperate situations, is the risk of intracranial hemorrhage bleeding directly into the brain.
The ultimate fear.
The risk of major intracranial hemorrhage with systemic lytics was more than 5 times higher than with anticoagulation alone. Think about what that means at the bedside.
It's devastating.
You have a 60-year-old patient who might be feeling a bit short of breath but is otherwise awake and talking. You give them a systemic clot buster to help their right ventricle, and you cause a massive, fatal, or severely disabling stroke.
Right, you traded a potential risk of right heart failure for an immediate catastrophic brain bleed.
Exactly. A 5-fold increase in bleeding into the brain. That single statistic created a decade of clinical paralysis.
Yeah, I mean, you have a patient who might be fine or might suddenly crash and die, and you have a drug that will definitely prevent the crash but might cause a fatal stroke.
Right.
So for the last 10 years, we've mostly just stuck to the garden hose. We admit them to the ICU or a high acuity step-down unit. We start the heparin drip, and we just stand there hoping they don't crash.
Yeah, we keep the clot busters locked in the Pyxis machine, using them strictly as a rescue therapy, meaning we only push the drug if the patient's blood pressure bottoms out and they actually start dying in front of us.
Which is stressful for everyone.
The entire field of pulmonary and critical care medicine has been absolutely desperate for a middle ground. We have been searching for a Goldilocks solution.
Right.
We need a way to harness the clot-busting, life-saving power of lytics, but we need to do it without triggering the systemic explosion of bleeding risk. The Holy Grail has been finding a way to deliver the drug locally, directly inside the clot itself, at much, much lower doses.
And that search finally brings us to the design, the engineering, and the execution of the HI-PEITHO trial. Because of that terrifying bleeding risk, the field needed a way to thread the needle.
Yep.
And HI-PEITHO is arguably the most rigorous, carefully constructed attempt yet to test one of these Goldilocks solutions. Let's really unpack how they engineered this trial, because the methodology is everything here.
It really is.
If you don't understand the design, you can't trust the results. This was a multinational, adaptive design, open-label, randomized controlled trial. They cast an enormous net. They screened 4,313 patients across 59 different clinical sites in the United States and Europe.
Right.
But here is the critical detail. Out of over 4,000 screened patients, they only randomized 544.
That sheer drop-off from over 4,000 to just over 500 is one of the most important aspects of the entire paper.
Really? Why is that?
Because they didn't just take any patient who walked through the door with an intermediate risk PE. If you design a trial and just include everyone with a slightly enlarged right ventricle and a slightly bumped troponin, your data gets incredibly muddy.
How so?
Well, because a huge percentage of those patients were going to be absolutely fine with just a heparin drip anyway.
Yeah.
If you treat people who were never going to crash in the first place, your fancy new intervention looks great, but it's an illusion.
Ah, right. It waters down the results.
Exactly. So the HI-PEITHO investigators utilize what we call enrichment inclusion criteria. They purposefully, deliberately narrowed the funnel to find the sickest of the sick, the patients who were truly teetering on the edge of the precipice.
The ones most mathematically likely to actually decompensate.
Exactly.
Okay, let's look at exactly what that gauntlet of enrichment criteria entailed. To even get into this trial, they couldn't just have a mild strain. The imaging criteria required an RV to LV ratio of 1.0 or greater.
Which means the right ventricle, that thin-walled sidekick we talked about had dilated to the point where it was equal in size to, or even larger than, the massive left ventricle.
Right.
That represents severe critical structural strain. And to give you an idea of how sick these patients actually were, the mean RV to LV ratio for the patients who made it into the trial was 1.6.
Oh, wow.
1.6.
These right ventricles weren't just a little stretch, they were massive. They were completely dominating the cardiac architecture.
So they had the structural strain of 1.6, and they had to have the elevated troponin, proving the heart muscle was actively suffering microischemia. But here's where HI-PEITHO separates itself from older trials, right?
Yay.
The imaging and the lab work were not enough. To get into this trial, patients also had to have at least 2 clinical indicators of cardiorespiratory distress.
Yeah, they couldn't just look bad on a CT scan or a blood test. Their actual vital signs had to be actively whispering that a systemic crash was imminent.
And we need to debate those distress markers because they are the key to the whole enrichment strategy. The investigators defined these clinical indicators very specifically.
What were they?
You needed at least 2 of the following: a systolic blood pressure of 110 millimeters of mercury or less, tachycardia defined as a heart rate of 100 beats per minute or more, or tachypnea, a respiratory rate of more than 20 breaths per minute, or frank hypoxemia.
Now, if I'm playing devil's advocate here, a respiratory rate of 21 and a heart rate of 102 doesn't exactly scream cardiogenic shock to a seasoned ER doctor.
Right, that could just be a Tuesday in the ER.
Exactly. Those are abnormal, sure, but a patient can be breathing at 22 simply because they are anxious or in pain. Why were these specific thresholds chosen to define a patient who is crashing?
It's a fantastic pushback. On their own, a heart rate of 102 or a respiratory rate of 22 might just be anxiety, but you have to view them in the context of the entire physiological picture.
Okay, fair.
This isn't just an anxious patient. This is a patient who has a massive clot in their lungs, a right ventricle that is 1.6 times the size of their left ventricle, and heart muscle that is leaking enzymes.
Yeah, that changes the context entirely.
In that specific context, a respiratory rate of 22 isn't anxiety. It is the body desperately trying to blow off carbon dioxide and pull in oxygen because cardiac output is plummeting.
Right.
A systolic blood pressure hovering at 108 isn't just a soft pressure. It represents the absolute maximum effort the failing heart can generate to maintain perfusion.
Right, they are maxed out.
Exactly. These parameters were chosen because they represent the ragged edge of compensation. And when you look at the patients they actually enrolled, 93% complained of dyspnea, roughly 78% were tachycardic, and nearly half were already hypoxemic.
Wow.
Yeah, these are not patients sitting comfortably in bed checking their phones while they wait for their heparin. These are patients who feel terrible, who look gray, and whose entire autonomic nervous system is firing on all cylinders just to keep them alive.
Okay, that context makes it completely clear. We have our highly enriched, high-risk, teetering on the edge patient population.
Yeah.
So what did they actually do to them? What was the intervention?
The test group received ultrasound-facilitated, catheter-directed fibrinolysis, plus standard anticoagulation. They utilized a very specific device called the ecosonic endovascular system.
Oh, this is cool.
Yeah, I want to pause here because for a lot of people, the term ultrasound catheter sounds a bit like science fiction.
Yeah.
How does beaming sound waves into a blood clot actually help dissolve it?
It's an incredibly fascinating piece of biomedical engineering. To understand it, picture the procedure.
Okay.
An interventional radiologist or cardiologist punctures the femoral vein in the groin, and they thread a specialized catheter all the way up through the venous system, through the right atrium, through that strained right ventricle, and park it directly inside the pulmonary arteries.
Just burying it right into the middle of the massive blood clot.
Exactly. Now, a common misconception is that the ultrasound is used to physically smash or pulverize the clot like a tiny mechanical jackhammer or a blender. That's not what's happening.
Right, it's much more subtle than that.
Much more. The device emits high-frequency, low-power ultrasound energy. What this acoustic energy does is create a phenomenon called acoustic streaming.
Acoustic streaming?
Yeah. Blood clots are held together by a dense, sticky mesh of fibrin strands. The ultrasound energy physically vibrates and thins out these fibrin strands, loosening the tight scaffolding of the clot.
Okay, I see.
By loosening that mesh, the ultrasound creates microscopic channels and exposes more plasminogen receptor sites within the clot.
Let me bring back a landscaping analogy for this.
Oh, I'm ready.
Using a standard IV drip of a clot buster is like trying to water a bone-dry, compacted lawn. The water just hits the hard surface and runs off. It doesn't penetrate.
Right, the runoff.
What this ultrasound catheter does is essentially aerate the lawn. It punches microscopic holes and loosens the dirt. So when you deliver the water, or in this case, the alteplase drug dripping out of the exact same catheter, it soaks deeply into the roots and the core of the thrombus, rather than just washing over the outside surface.
Aerating the lawn is a superb way to visualize the mechanism, because the ultrasound loosens the clot architecture, and because the drug is being delivered directly into that porous center, you can use drastically lower doses of the powerful clot buster.
How much lower?
Well, in the HI-PEITHO trial, for a patient who had catheters placed in both their right and left pulmonary arteries, the mean total dose of alteplase administered was only about 17 milligrams, delivered slowly over roughly 7 hours.
Wow.
Compare that to the old 2014 systemic lytic approach, which might push 100 milligrams through a peripheral IV in just 2 hours. The catheter approach is a fraction of the total dose, delivered locally, directly to the site of the problem.
So that is our intervention group. The control group, meanwhile, received standard anticoagulation alone, which is the usual care, mostly unfractionated heparin drips or subcutaneous low molecular weight heparin.
Right.
And the trial protocol was incredibly aggressive regarding time. They required the catheter intervention to be initiated within 6 hours of the patient fulfilling all those strict criteria.
They didn't want to wait around.
Not at all. In reality, they were even faster. For nearly 3/4 of the intervention group, the therapy started within 2 hours of randomization. They didn't wait around to see how the patient did overnight. They moved with purpose.
And that speed was essential to the trial's core philosophy.
Yeah.
The entire goal was to test early, preemptive stabilization. They wanted to beat the crash, not react to it.
But this brings us to a massive, glaring methodological problem that we have to debate.
Uh-oh, what is it?
This was an open-label trial.
Right.
The doctors, the nurses, the patients, everyone knew who was getting wheeled down to the cath lab for the cool new ultrasound device. And everyone knew who was just staying in their bed getting a standard heparin drip.
Yeah, it's tricky.
If your primary outcome includes something as potentially subjective as clinical deterioration, doesn't an open-label design introduce massive fatal bias into your results?
I absolutely can.
Let's be real. If I'm the treating physician at 3 a.m. and my patient was randomized to the control group and is just on heparin, might I subconsciously panic a little earlier? Might I be quicker to declare them deteriorating so I can jump in and give them rescue therapies because I know they didn't get the fancy catheter?
You are hitting on the fundamental flaw of almost every interventional device trial in modern medicine. Expectation bias from the local investigator is a huge, persistent confounding factor.
It's just human nature.
It is. It's almost impossible to completely blind a surgical or catheter procedure. If the treating physician believes deep down that the catheter works better, they will inevitably, even subconsciously, manage the control group differently.
Right.
They might have a lower threshold to intubate or a lower threshold to start pressors. The HI-PEITHO investigators were acutely aware of this Achilles heel, and they built several incredibly robust interlocking defenses against it to protect the integrity of their data.
How exactly do you protect against human nature in an open-label trial?
First, they employed an independent, blinded clinical events adjudication committee. The local doctor might say a patient decompensated, but the ultimate decision of whether an endpoint was actually met was made by a panel of experts looking at anonymized data who had no idea which group the patient was in.
Okay, that's a good start.
But their second, and much more important defense, was stripping away the subjective opinion of the local doctor entirely. They did this by mandating an objective, standardized mathematical metric to define what deterioration actually meant.
And that metric was the National Early Warning Score, or the NEWS score.
Yes, the trial protocol defined cardiorespiratory decompensation with draconian strictness. It wasn't enough for the local doctor to write in the chart, "The patient looked worse to me," or "patient appeared fatigued."
They needed hard numbers.
Exactly. Decompensation had to be defined by hard, undeniable events. frank cardiac arrest, objective signs of shock with documented end-organ hypoperfusion like kidney failure, the physical need for mechanical ventilation, or a new WS score that rose to or persisted at a value of 9 or higher, confirmed by 2 separate measurements taken 15 minutes apart.
We really need to deconstruct this new WS score because the entire trial hinges on it. The new WS score is a composite physiological score.
Right.
It assigns points based on respiratory rate, oxygen saturation, need for supplemental oxygen, temperature, systolic blood pressure, heart rate, and level of consciousness, usually using the AVPU scale: alert, voice, pain, unresponsive.
It covers everything.
Yeah. A score of 9 is not just a mild fever and a fast heart rate. A score of 9 is high. It is a calculated, objective, mathematical threshold that screams, this patient's physiology is collapsing.
Yep.
By forcing the use of that specific threshold, it completely removes the local investigator's subjective feelings from the equation.
Right.
It doesn't matter if the doctor feels anxious, the patient's vital signs dictate the outcome. It is a brilliant way to neutralize open-label bias.
It really was. They took a difficult situation, you can't blind a catheter procedure, and they engineered a strict, bias-resistant, objective hurdle for this Goldilocks intervention to clear. They enriched the patient population to ensure they were only studying sick patients, and they hardened the endpoints to ensure they were only measuring real clinical events.
So we have an incredibly solid setup. We have 544 highly selected, severely ill patients. We have a localized, low-dose, ultrasound-facilitated intervention.
Yeah.
We have rigorous, objective
The
endpoints.
stage is set.
The question is, what actually happened when the dust settled at the 7-day mark? Let's look at the results, because this is where the data gets incredibly clean, but also requires some heavy critical analysis.
Let's start with the primary efficacy outcome. This was a composite endpoint measured at 7 days. The composite bundled together 3 things: PE-related death, cardiorespiratory decompensation or collapse, or symptomatic recurrence of the pulmonary embolism.
This is the headline of the paper, the big win. The numbers are striking.
What were they?
In the intervention group, the ultrasound catheter group, a primary outcome event occurred in 4.0% of patients. That was exactly 11 patients out of the 273 randomized to the catheter.
Okay.
In the control group, the standard heparin care group, a primary outcome event occurred in 10.3% of patients, or 28 out of 271.
When you run the statistical math on those event rates, it translates to a relative risk of 0.39. That represents a massive 61% relative risk reduction in the primary outcome.
That's huge.
But in clinical medicine, we often care more about the absolute numbers. The absolute difference between the two groups is 6.3 percentage points. That allows us to calculate the number needed to treat, or the NNT, which is roughly 16.
Okay, let's break that down.
What that means at the bedside is that for every 16 intermediate-risk PE patients you treat with this ultrasound catheter, you will prevent 1 instance of death, decompensation, or clot recurrence within that first critical week. In the world of complex cardiovascular interventions, an NNT of 16 is a very strong, very clear signal of efficacy.
I'm going to push back hard right here, though.
Oh.
As you said, the primary outcome is a composite, and composites in clinical trials can be incredibly tricky, sometimes even deceptive.
Fair.
Trialists use them because bundling multiple outcomes together increases the total number of events, which gives the trial the statistical power to reach a p-value of less than 0.05, much faster and cheaper than tracking a single rare event like death.
Exactly. It's a pragmatic choice.
But they bundle radically different things together. A PE-related death is a catastrophic permanent tragedy. A spike in heart rate and respiratory rate that temporarily bumps your no-WS score to a 9 is a transient physiological alarm.
Right.
Treating those two things as mathematically equal in a primary endpoint makes me nervous. Were we actually saving lives in this trial, or were we just moving the needle on a softer physiologic metric? We have to deconstruct this composite. Why did the catheter group win?
Your skepticism is entirely validated, and it's exactly how critical care doctors need to read these papers. We absolutely must deconstruct the composite to see the naked truth of the trial.
Let's see the truth.
And the truth is this. The statistical victory was driven entirely by preventing cardiorespiratory decompensation. The rate of decompensation was 3.7% in the catheter group versus 10.3% in the control group.
Ah, so that's the driver.
That delta is where the massive benefit lies. The intervention stabilizes the erratic vital signs. It prevents the crashing NUWS score. It prevents the need for intubation.
And what about actual mortality? What about PE-related death?
This is the crucial finding that every clinician must memorize. Mortality was incredibly, phenomenally low in both arms of the trial. In the 7-day window, there were actually 3 PE-related deaths in the intervention group and only 1 in the control group.
Wait, 3 versus 1?
Yeah. Now, that difference is not statistically significant. It's likely just statistical noise given the tiny numbers. But it firmly, unequivocally tells us that we are not averting death in this specific short-term window.
Right.
Furthermore, the rate of recurrent pulmonary embolism was identical. Exactly 1 patient in the catheter group and 1 patient in the control group.
So if we're perfectly honest about the data, the headline of this trial isn't "Catheters Save Lives." The headline is "Catheters Keep Patients from Crashing in the First Week."
Yes.
Which, to be fair, is still clinically huge.
Yeah.
Preventing a crash prevents trauma to the patient, but it's a very different mechanism of benefit than extending a lifespan.
It is a different mechanism. But we have to contextualize why the mortality was so incredibly low in the control group. It wasn't because standard heparin is a miracle drug.
Right, why didn't they die?
It's because the trial protocol specifically mandated and allowed for rescue therapy. This wasn't the 1960s where we just let people die. If a patient in the control group decompensated, if their NUWS score hit 9 and they started spiraling, the local investigators were allowed to cross them over and hit them with rescue treatments.
Oh, I see.
That rescue therapy might include systemic lytics, it might include putting catheters in later, or it might involve putting them on full cardiopulmonary bypass with ECMO.
Extracorporeal membrane oxygenation.
Exactly. And the data shows this. Nearly 10% of the control group required some form of rescue therapy. So we didn't let the control group die. We actively rescued them when they fell off the cliff.
That makes perfect sense.
What the ultrasound catheter intervention essentially does is act as a guardrail. It prevents the patient from ever falling off the cliff, thereby preventing the need for that dramatic, often highly dangerous last-ditch rescue.
That reframing makes perfect sense. The catheter is the guardrail, not the parachute. Okay, so we've firmly established the benefit, a 61% relative reduction in physiological crashing and the need for rescue.
Yep.
But in medicine, every intervention has a cost. And I don't mean the financial cost of the catheter yet. I mean the physiological cost. What about the safety outcomes?
The big question.
After the trauma of the 2014 PRISM trial, the bleeding question is the only thing clinicians truly care about when you mention the word lytics. Did the lower dose of alteplase still crush the roof of the house?
This is the section of the paper where clinicians will finally breathe a massive sigh of relief. Let's look closely at major bleeding at 7 days. It was 4.1% in the ultrasound catheter group compared to 2.2% in the standard heparin control group.
Okay, so a little higher.
While that is numerically higher in the catheter group, the p-value was 0.32, meaning it was not statistically significant. We can't definitively say the catheter caused more bleeding.
Right.
If we extend the window to 30 days, the rate of major bleeding was 4.1% versus 3.0%. Again, a p-value of 0.64. Still not statistically significant.
But the single most important data point in this entire paper, the one sentence that will allow physicians to actually sleep at night after prescribing this procedure.
0 intracranial hemorrhages in either group. 0 out of 544 highly stressed, very sick patients.
That is the holy grail. We finally found a way to deliver the alteplase, get the rapid hemodynamic and physiologic benefit of melting the clot, and entirely avoid the catastrophic risk of bleeding into the brain.
It seems like the Goldilocks solution actually worked exactly as engineered.
It really does. But before we declare total unmitigated victory and start putting catheters in everyone, there is a fascinating nuance buried deep in the supplementary data regarding hospital resource utilization.
Oh, the ICU number.
Yes. It's a logistical paradox. If this catheter intervention is so phenomenally great at preventing decompensation and keeping patients stable, why did I read that 71.1% of the intervention group were admitted to the intensive care unit, compared to only 50.2% of the control group?
That's a great question.
If the catheter makes them more stable, shouldn't they be transferring out to the general medical ward?
That is a brilliant observation, and it highlights the real-world logistical friction that clinical trials often gloss over. It exposes the intensely resource-heavy nature of the intervention itself. Think about what is actually physically happening to this patient.
Okay.
To get this therapy, they're being transported out of the ED to a cath lab or an interventional radiology suite. A highly trained physician is using ultrasound to puncture their femoral vein, threading wires through their right heart and leaving plastic catheters indwelling in their pulmonary arteries.
Right.
Then they are transported back to a nursing unit where they are receiving a continuous infusion of a powerful thrombolytic drug, alteplase, directly into their chest for over 7 hours. And usually, they're also on a concurrent heparin drip to prevent the catheters themselves from clotting.
Right. So regardless of how stable their vital signs look on the monitor, hospital protocols and basic medical prudence dictate that a patient with bilateral pulmonary artery catheters dripping a clot buster needs intense 1-to-1 or 1-to-2 nursing ratios.
Exactly.
They need frequent access site checks in their groin for bleeding. They need neurological checks every hour to ensure they aren't having a stroke. You practically mandate an ICU bed, or at least a highly specialized step-down unit, simply by choosing the therapy, regardless of the patient's physiology.
Exactly. The control group, the garden hose group, just needs a peripheral IV for a heparin drip. If they look stable, they can often go to a regular telemetry floor with a 1-to-4 nursing ratio.
That's a huge difference in resources.
So while the catheter prevents the clinical crash, it actively increases the logistical burden on the hospital system up front. You are making a trade.
Right.
You are trading the terrifying, unpredictable, chaotic resource drain of a sudden code blue and an emergency intubation on the ward for the predictable, planned, but highly expensive resource drain of an elective ICU admission and a 2-hour procedure in the cath lab.
Unpredictable chaos versus planned resource allocation. That is a phenomenal way to frame the reality of modern medicine.
It really is.
The numbers look great, the trial design was rigorous, the safety profile is incredibly reassuring, but how is the broader medical community actually interpreting this data? Let's turn to the NEJM editorial by Dr. Spyropoulos and Dr. Vedantam, because they do a masterful job of reading between the lines and providing the necessary skepticism.
The editorial is a masterclass in balanced, critical interpretation. They start by giving the HI-PEITHO trial its well-deserved due. They explicitly call it a major advance in the foundation of evidence for interventional thrombolytic approaches.
Which it is.
And it truly is. For years, people have been using these ecosonic catheters based largely on retrospective registries, single-arm observational studies, and vocal expert opinion. HI-PEITHO finally provides randomized, controlled, high-quality, multi-center evidence that standardizes what we previously considered rescue therapy and conclusively shows a lower major bleeding risk compared to the older systemic iolytic data.
It formally legitimized the therapy in the eyes of evidence-based medicine.
Exactly.
A major advance. But as with all things in critical care, it comes with asterisks. And the editorial highlights several crucial caveats that we really need to debate, because these caveats dictate how we use this tomorrow.
Let's hear them.
Let's start with the surrogate marker for decompensation, the NUWS score. The editorial points out that while the NUWS score is highly validated and widely used in health systems across Europe, it is simply not widely used in North America. Is this a clinically relevant surrogate for American doctors?
It's a highly valid critique. If you are an American physician, you might use a completely different early warning system, like the MUWS score or the Rothman index, or more likely, you might rely heavily on clinical gestalt, your hard-earned intuition of when a patient is crashing.
Right, the IPAL test.
Yeah. If the primary endpoint of a massive trial is heavily driven by a proprietary scoring system that your specific hospital doesn't even use in its electronic medical record, it creates a slight cognitive disconnect.
So you start doubting the results.
You have to ask yourself, does a new WS score of 9 truly equal a meaningful clinical event in my specific practice? The investigators argued strongly that it does, because a score of 9 represents undeniable objective physiological derangement across multiple organ systems. But the editorial rightly flags it as a potential psychological barrier to translation for North American readers.
Okay, here is the asterisk that gave me the most pause when reading the supplementary data, the missing patients.
Oh, yeah.
Remember that massive screening funnel we talked about earlier? They screened 4,313 patients. They excluded 3,769 of them. Now, most of those exclusions make perfect sense. They just didn't meet the strict inclusion criteria.
Right. Normal troponin, normal BP.
Maybe their troponin wasn't quite high enough or their blood pressure was too normal. That's fine. That's just the trial design working as intended. But 321 patients were excluded for other or unknown reasons.
That's a lot of unknowns.
That is a massive chunk of patients who theoretically met the criteria but just vanished from the trial without explanation.
It is a staggering number.
Yeah.
321 patients is more than half the total number they actually randomized into the entire trial.
Right.
When you have that many unknown exclusions in an interventional trial, it inevitably raises massive questions about real-world generalizability and selection bias.
Like, who are these people?
Exactly. You have to wonder, did the local investigators consciously or subconsciously cherry pick? Did they look at a frail 85-year-old patient who technically met the criteria but looked incredibly fragile and decide, I'm not putting her in the trial, she's too high risk?
Or conversely, did they keep the easiest, healthiest looking cases out?
We simply don't know. The editorial is essentially saying, we love the clean data we have on these 544 patients, but we are extremely nervous about the 321 patients we don't have.
That's a great point.
It means we have to be incredibly careful about assuming this trial's safety and efficacy applies to absolutely every single intermediate risk patient that rolls through the ambulance bay doors.
And then there is the bleeding shadow. We spent time celebrating that the bleeding difference wasn't statistically significant, 0 ICH. But the editorial taps the brakes hard here.
They do.
They note that major bleeding was numerically higher in the catheter group 11 patients bled versus 6 in the control group at 7 days.
Right.
The p-value didn't hit the magical 0.05 threshold, but when you have a long history and deep, painful experience with fibrinolytic drugs, you know they cause bleeding. The editorial essentially warns us, do not get complacent.
Which is very fair.
The bleeding risk cannot be entirely discounted just because the p-value didn't trigger significance in a relatively small trial of 500 people.
That is the hard-earned wisdom of experienced trialists. Absence of statistical proof is not proof of absolute safety.
Right.
When you put a large plastic catheter into a major vein and drip a powerful enzyme like alteplase for 7 hours, someone somewhere eventually is going to bleed. You have to respect the drug, and you have to respect the procedure.
Finally, the editorial points out something that feels a bit underwhelming after all this high-tech intervention, the functional outcomes.
Yeah, this was interesting.
If we are putting in these expensive catheters, taking up ICU beds, and rapidly melting the clot, you would assume the right ventricle would look vastly better on an echo, and the patient would feel vastly better when they walk.
You would hope so.
But the early effects on the RV to LV ratio at 48 hours were not overly impressive. And the 6-minute walking distance at 30 days, it was 405 meters in the catheter group versus 393 meters in the control group.
That's pretty close.
That's a 12-meter difference. 12 meters is practically the margin of error for someone having a slightly better day.
It is underwhelming, but it's also a dose of physiological reality. It tells us that while the catheter is phenomenal at preventing the acute, life-threatening physiological crash in week 1, it doesn't magically cure the patient's underlying disease by day 30.
Healing takes time.
It does. The body still takes a long time to heal. The stretched right ventricle still takes weeks or months to remodel and recover its tone. And the patient still feels the lingering fatigue and effects of a massive cardiovascular insult.
Right.
The editorial correctly notes that we desperately need the 12-month follow-up data to understand if there is a genuine long-term functional benefit like preventing chronic thromboembolic pulmonary hypertension, or if we just successfully smoothed out the terrifying first 7 days.
So when you synthesize all of this, the big win on preventing decompensation, the highly reassuring safety profile, but all these valid, weighty asterisks from the editorial, what is the final takeaway from the experts?
The editorial concludes that the HI-PEITHO findings firmly support a lower threshold for utilizing ultrasound-facilitated catheter-directed thrombolysis. It absolutely does not support a universal mandate for every single intermediate-risk patient.
A lower threshold?
Yes. It gives you the solid, randomized evidence you need to act earlier in your sickest, most tenuous patients. But it doesn't say you are committing malpractice if you choose standard anticoagulation and careful ICU observation for an intermediate-risk patient who looks clinically stable.
A lower threshold, not a universal mandate. That perfectly transitions us to the most important part of this deep dive.
Let's bring it to the bedside.
Let's step out of the journal pages, let's leave behind the statistics, the p-values, and the inclusion criteria, and let's walk into the hospital. You are the listener. You are an attending ICU doc, an ED physician, or a pulmonologist. You are on a PERT call, a pulmonary embolism response team call.
Which, for those unfamiliar, is a multidisciplinary rapid response team designed specifically to crowdsource the best treatment plan for complex PEs.
Exactly. So your pager goes off at 2 a.m.
The classic dread-inducing consult.
Yep.
You answer the phone and the resident says, I have a 60-year-old patient in the ED. They are hemodynamically stable, blood pressure is 115/75. But the CT scan shows massive right ventricular strain, the RV to LV ratio is 1.3, and their troponin is highly positive. What do we do?
What do we do? Let's look at the paradigm shift. Before HI-PEITHO was published, what was the standard accepted answer at 2 a.m.?
Before HI-PEITHO, the answer on that call was almost universally, Anticoagulate them fully with heparin immediately. Put them in a continuously monitored bed, maybe a step-down unit or the ICU depending on your hospital's protocol. Watch their vital signs incredibly closely.
Wait.
And we will wait to escalate to catheters or systemic licks only if they start to deteriorate. It was a pure strategy of rescue therapy. Let the fire burn, but keep the water bomber fueled and on standby on the runway.
And after HI-PEITHO, how does this trial fundamentally change that 2 a.m. conversation tonight?
This trial nudges the entire multidisciplinary team toward earlier intervention in selected patients. It gives you the peer-reviewed data to look at the team and say, I don't want to wait for the crash. We have proof we can prevent it safely.
But the operative word is selected.
Highly selected.
It brings us to the first practical implication for your practice: nuanced risk stratification. Not all submassive or intermediate risk PEs are created equal anymore. Imaging is no longer enough to make the decision. A big right ventricle on a CT scan doesn't automatically buy you a catheter procedure.
Right, because the trial specifically enriched for physiologic distress.
Right.
So on that 2 a.m. call, you aren't just asking the resident to read the echo report to you.
No, you need more.
You are asking, what is their heart rate right exactly now? Are they breathing 24 times a minute while sitting still? Is their blood pressure hovering at 108?
Physiologic distress is the critical trigger for action.
Yes.
If they have the big RV, the positive troponin, and they are tachycardic and tachypneic, HI-PEITHO says this specific patient is highly likely to decompensate, and a catheter will almost certainly prevent it.
Exactly. It changes the entire framing of the risk-benefit conversation. Instead of, let's wait and see if they survive the night, the question becomes, should we intervene preemptively right now before they crash?
You're moving from a reactive defensive posture to a proactive offensive posture.
Exactly.
The third implication is about the legitimacy of the procedure itself within the hospital ecosystem. For a long time, catheter-directed therapies were very center-dependent.
Oh, very much so.
If your hospital had a champion interventional radiologist or an aggressive interventional cardiologist who loved doing these procedures, you did a lot of them.
Yeah.
If you didn't have that champion, you didn't do them.
Right.
HI-PEITHO moves the therapy firmly out of the realm of slick, doctor-dependent tool and into the realm of evidence-supported intervention. It legitimizes the therapy across the board.
But we have to balance that new legitimacy with the fourth sobering reality, which is the not-for-everyone reality.
True.
When you are on that PERT call, you have to remind the enthusiastic junior members of the team that this intervention offers zero proven mortality benefit. It is not a life or death emergency to place that catheter at that exact second if the patient is stable.
It costs a lot of resources.
Highly resource intensive. If you say yes to the catheter at 2 a.m., you are waking up an interventional team, you are committing an ICU bed, and you are committing specialized one-to-one nursing resources for the next 12 hours.
It's a big deal.
It requires specific institutional expertise and deep pockets. You cannot just mandate this everywhere tomorrow without breaking the hospital's logistics.
So basically, prepare for a lot more phone calls to interventional radiology.
Yes, probably a lot more phone calls to IR and a lot more grumbling from the nursing supervisors trying to find an open ICU bed.
And a lot more intense debates at 2 a.m. about whether this specific patient is truly sick enough to warrant the massive resource expenditure and the small but very real bleeding risk.
Precisely. This trial doesn't make the peer decision easier. It makes the decision much more nuanced. It provides a powerful, proven new tool, but it demands vastly better clinical judgment to wield it correctly.
Right.
It's moving the needle of pulmonary medicine from purely rescue therapy toward preemptive stabilization.
And that is the perfectly balanced take. This trial is not a sweeping mandate to change all practice overnight. It's a shift in the tectonic plates of how we view risk, physiology, and timing. Let's do a quick repetition for retention. If you are walking into your clinical shift right now, what are the core takeaways you need to remember from the HI-PEITHO trial?
Number 1, in intermediate risk PE with concrete signs of physiological distress, ultrasound-facilitated catheter-directed thrombolysis significantly reduces clinical deterioration and prevents the physiological crash.
Okay.
Got it. Number 2, it does not clearly reduce mortality in the short term.
Right.
Number 3, the bleeding risk appears highly acceptable with absolutely no increase in intracranial hemorrhage in this specific trial.
A big win.
And number 4, in the short term, This will likely impact middle-of-the-night PERT decision-making more immediately than it will alter overarching global Class 1 guidelines.
This is a trial that doesn't end debates, it starts new ones.
And as we look to the future, we have to wonder what those new debates will look like. What happens when the 12-month follow-up data comes out? Will we finally see a divergence in chronic heart failure symptoms?
That's the hope.
Or, as the editorial provocatively suggests, what if we pair mechanical thrombectomy, where we physically suck the clot out with large-bore catheters without using any relytic drugs at all, with safer, next-generation background anticoagulants like factor XI inhibitors?
Factor XI inhibitors.
Right, they target the contact pathway of coagulation, potentially uncoupling hemostasis from thrombosis, meaning they might prevent clots without causing surgical bleeding.
That would be incredible.
If we can eliminate the bleeding risk entirely with better drugs and purely mechanical tools, will we eventually be treating even lower-risk patients this aggressively? It's a fascinating horizon, and it probably changes how we talk through intermediate-risk PE at 2 a.m. from now on.
And until those next-generation tools arrive, we keep evaluating the physiology, we keep weighing the risks of the water bomber versus the garden hose, and we keep answering the pager. This episode is for educational purposes only and not medical advice. Clinical decisions should be made in the context of individual patient factors and institutional expertise. This episode was generated using AI voices, and occasional mispronunciations may occur.